Okay, good morning, everybody. We're going to talk today about some genodermatoses, which are quite a few things to look at here. So basically, we're just going to kind of talk about the skin manifestations that are associated with different genodermatoses. This is an example of basically just a generic ichthyosis, okay? And when you look at the ichthyoses, it's kind of a broad category. They talk about lamellar and epidermolytic hyperkeratosis and ichthyosis vulgaris. The main features of the ichthyoses, people talk about loss of the grain or cell layer and things like that. Don't worry as much about that. Mainly just notice that the cornified layer looks like plates of keratin stacked and compacted upon itself like this, without any significant epidermal hyperplasia. Now, the lamellar ichthyosis may get some psoriasis from hyperplasia, but it's not usually dramatic like you see, like you don't see here, and you don't see in psoriasis. So when you see something that looks like this, that's got these plates of hyperkeratosis just stacked on one another, and this isn't lichen simplex here. This is ichthyosis, and this would probably be more than acquired ichthyosis. When you get this kind of thickness in it like this is kind of what you start seeing when you get things like lamellar ichthyosis, harlequin ichthyosis, things like that, where you get a really, really thick cornified layer. Now, I would recommend, if you just saw something like this, I don't think the board's going to ask you to really get into the difference in the histology of the ichthyoses, but you need to know what syndromes are associated with ichthyosis, like Conradi-Huneman, for example. They can give you an ichthyotic-like eruption. Some of the other conditions, I would strongly recommend that you guys learn all of the various Sjogren-Larsen, all those kind of things that are associated with ichthyotic skin conditions. So this is where you look at this, recognize the cornified layer has got this markedly thickened cornified layer with just individual plates of hyperkeratosis stacked one on another. And that's basically just generic quote ichthyosis, and then know the various syndromes that can be associated with that. Know the loss of steroid sulfatase, so know all those various kind of things. X-linked, acquired ichthyosis, lamellar ichthyosis, and then the various syndromes associated with ichthyosis. Now you can see ichthyosiform eruptions in patients that have things like lymphomas and whatnot. That usually doesn't give you this thick of a cornified layer. The cases that I've seen of that look a little bit more like acquired ichthyosis. And if you take a look at somebody that's got severe xerotic dermatitis, that can sometimes look a little bit like acquired ichthyosis as well, but generally you tend to get more of the laminated orthokeratosis like we see here. Not as thick as this, but laminated orthokeratosis in acquired ichthyosis. Okay, so that's the first thing that's associated with the syndrome. Now, what do we have here? We've got intraepidermal acantholysis. Okay, so the reaction pattern here in this one, to me, looks more like focal acantholytic dyskeratosis. So when you see focal acantholytic dyskeratosis, you should be thinking in terms of things like Darier's disease, Grover's disease, familial dyskeratotic comedones. There's about 5 or 6 different conditions that can give you focal acantholytic dyskeratosis. So when you see this, if they showed you somebody that had a widespread eruption in the sebaceous seborrheic dermatitis-like areas of the skin, the anterior chest, scalp, face, nails involved with notching and with the elongated erythematous and white ridges, obviously the diagnosis is Darier's disease. So the situation here is recognizing the reaction pattern, focal acantholytic dyskeratosis, knowing that that can be associated with about 5 or 6 different things, especially when it's widespread, not just a solitary lesion, say with a solitary keratosis or with, say, a warty dyskeratoma, then understand Darier's disease and then know the biochemical abnormality of Darier's disease when that develops, the calcium channel situation there associated with the dyskeratosis seen with Dario. So this is focal acantholytic dyskeratosis, corones and grains, okay, corones, round bodies. Those are acantholytic dyskeratotic cells usually seen in the in the granular cell layer or in the suprabasilar areas. And then grains are acantholytic, dyskeratotic, parakeratotic nuclei like you see up here. So it's not specific for diarrhease. It can be seen in any of the situations where there's acantholytic dyskeratosis, but realize that that's a syndrome, autosomal dominant diarrhease disease. Okay. The next one is also gives you an intraepidermal acantholytic process. And we'll look at the bottom one here. And we see confluent dyskeratosis and acantholysis extending from the basal cell layer all the way through the epithelium. So there's a subepidermal cleft, but then notice at the surface, the overlying roof has also got a lot of acantholytic change to it. So this is Haley-Haley disease, also genetically inherited autosomal dominant. And you all know what that looks like, macerated areas in the intertriginous areas where the skin gets traumatized, like the neck, kids wearing backpacks and whatnot. They can get Haley-Haley disease on their neck or shoulders, but it's most commonly seen in the groin area or in the axilla. And this is the so-called dilapidated brick wall appearance. So notice that there's acantholysis. It's not just suprabasilar, it also extends into the roof of the blister. Lots of acantholysis, a lot of crusting, a lot of scale crust. A lot of these patients can have secondary candidal infections, bacterial infections, even herpes infections can develop in lesions of Haley-Haley disease. So you always want to be looking to make sure there's not a superimposed infectious process there. Okay, the next two slides, not really a syndrome per se, but often seen in children. And so basically these kids come in, they may have a loss of hair on the scalp. They may have a little rim of hypertrichosis around this. And notice here, there's thinning of the epidermis. There's total loss of all adnexal structures in this area. And as you go to higher magnification, you can even see that the dermis is really abnormal. This is really a very loose, loose connective tissue here. It almost looks like it's really just poorly formed. It almost looks like little fetal fibroblast, and it's fibromyxoid. It's got these spaces in here. These are not blood vessels, they're just dilated spaces. And this is Aplasia cutis congenita. Okay, when you see this isn't really a syndrome per se, but it can be associated with other things sometimes. But basically, it's loss of the dermis. So basically, it's basically just an area of the skin really is malformed. And notice that even though it says aplasia cutis, well, there's still some skin there, but it doesn't have any adnexal structures. It's abnormal here, as you can see. And we have another slide that shows the same thing. And so you can see in this this other example, this almost always occurs on the scalp. Shows you this there. It's almost kind of a wedge-shaped area that's just, it's not really a scar. It's basically just this abnormally formed dermis where the epidermis is thin and you don't have any adnexal structures in this area. So this one has got more kind of fibrous tissue, probably a later stage lesion, and actually kind of formed kind of a scar here a little bit. The other one has got that kind of almost primitive fetal looking dermal connective tissue, and a little bit of that mucinous kind of stroma here too. So this is aplasia cutis. So just the main thing here is just notice that it's an area, it's not really traumatized. I mean, this was present at birth. They excised it, and you can see that it's just got this abnormal collagen in here in the dermis, and there's no adnexal structures here. And one thing to always be concerned about when you're dealing with an area of aplasia cutis or an area that looks like it's atrophic on the scalp, make sure there's not any loss of underlying bone, and you're not kind of getting into a possibility of, say, something that's dealing with the meninges or the ependema beneath this. So beware of operating and doing surgery on that, because you never know. There might actually be loss of the bone underneath it, and you might actually go in and cut right into the, usually it's a child, you might actually cut into their central nervous system, their brain. So I recommend before you do any procedure on the lesion that looks like aplasia cutis, you should do an x-ray and make sure that there's no loss of any of the table of the bone. Okay, this is another example here, and this is something that would be fair game for the boards. This is a cell pore blister. Okay, so it's a subepidermal blister, and whenever you get, and I'm not even 100% sure it's really subepidermal. Unfortunately, there's something wrong with the computer today. It keeps blinking out on us. But anytime you see a cell pore blister, it's either going to be subepidermal. It might be at the junction of the epidermis and the dermis, and then it also might be inside the basal cell layers itself. So it actually could be, and it could even be in the dermis, depending on where it is, if it's one of the mechanobullous disorders. So this would be a nice example. This one just says epidermolysis bullosa. I don't know which one it is. This could be possibly the Letalis form, Hurlitz. Usually, you don't see any scar in that. You might see, if you do see an abnormality in the dermis, it's very subtle. You still have some festooning and some residual papillary dermal collagen here. So that wouldn't necessarily exclude the Hurlitz type of EB. I'm sorry about this. It's not functioning properly today, but it would tend to maybe favor something like maybe epidermolysis bullosa simplex. Now, if you start getting scar tissue that's formed, then you're dealing with one of the dystrophic forms of EB. The recessive form obviously gives a lot of scar tissue. Eventually those patients pass away from squamous cell carcinoma that develop in these lesions. So the more scarring you have, the deeper the blister. And if it's more superficial, if it's actually in epidermolysis bullosa simplex, if you look carefully, you might actually see the blister forming in the basal cell layer itself. Now, I don't see that here. So that tells me that it may be, it's probably not Weber-Cockayne. It may be one of the other forms of the simplex forms that usually splits right at the level of the lamina lucida, like you would see here. If you actually see true, like Weber-Cockayne, you can see often dissolution of the basal cell cytoplasm itself there. So that's kind of subtle to see under the microscope. But just remember, if you've got one of these subepidermal blisters, it looks like this with minimal inflammation, you should be thinking about one of the mechanobullous diseases. And I would recommend, they're probably not going to ask you a lot of questions on that, but you should at least know the major genetic abnormalities and the major loss of proteins and things of that nature, the loss of the anchoring fibrils and the type 7 collagen abnormalities that are associated with the various forms of epidermolysis bullosa. So that you may as well, kind of learn those, because that's a pretty simple question to get on the exam. It's pretty straightforward histologically. If you just know what the differential diagnosis is and kind of notice if there's scar, it's more likely to be one of the dystrophic forms. If there's not scar, it's going to be more simplex or Letalis. And if it's present at birth in a neonate with this widespread extensive blistering, that's obviously more common in the Letalis forms. There's an old mnemonic device, We Shall Learn Derm, which basically talks about the thickness of of where these blisters occur. Weber-Cockayne occurring at the top of that, and then simplex, and then Letalis, and then the dystrophic forms. That's kind of a little mnemonic device you can use to kind of remember that. Okay, next one. Low magnification basically looks like no inflammation, but there's something going on in the reticular dermis. And as we go to higher magnification, it's got this beautiful example of the steel wool appearance of the elastic fibers here that are calcified. And this is pseudoxanthoma elasticum. Again, a genodermatosis associated with chicken skin-like morphology of these yellowish areas, often present around the neck. They get the fractures in the Brooks membrane of the eye. And so again, this is I believe it's the autosomal dominantly inherited process. Again, can be associated with abnormalities in anywhere there's elastic tissue, the aorta, the eye. You get abnormalities in those situations as well. They can get aortic aneurysms that rupture. So again, it's a serious disease, and you want to make sure that you make the diagnosis properly. And this is pathognomonic of what you see under the microscope. You get these coiled elastic fibers that are got these little pinkish, this purplish structures, which are little small spicules of calcium that are in the elastic fibers as well. And there's two types. There's the genetic type of PXE, and then there's the acquired type of PXE. And there's actually two sort of forms of acquired type. There's the type that can be associated with penicillamine. And if you look carefully at the elastic fibers in that, they kind of give you these little, what's called bramble bush morphology. They're these little tiny sort of extensions at right angles with these little bulbous aggregations on there of the dystrophic calcification of the elastic fibers. And that's when you see when penicillamine causes the eruption. If it's seen, you can also see it in patients that have sclerotic skin from other reasons. Sometimes you see it in necrobiosis lipoidica, for example. It's been reported in patients that don't have PXE in periumbilical plaques, patients that have repeated pregnancies. They get this dystrophic stria. You biopsy one of those and it shows PXE. So it can be acquired related to trauma in that situation, and it can also be acquired due to penicillamine ingestion. So just be aware of the different ways that you can get PXE. All right, the next genodermatosis is neurofibromatosis. And if you see a plexiform neurofibroma, so here you've got, this is a deep neurofibroma, it's deep to the skin. You've got multiple little sort of islands of neurofibromas clustered together almost like a bag of worms. That is a plexiform neurofibroma, and that is almost pathognomonic of neurofibromatosis type 1. So if you see a plexiform neurofibroma, you really need to make sure your patient doesn't have von Recklinghausen's disease. Sometimes they can have a form frust of it. They may just have one plexiform neurofibroma, and then maybe someone down the line gets a more serious widespread manifestation of the disease. But certainly you want to diagnose this if you see a plexiform neurofibroma. You want to think in terms of the possibility of NF1 neurofibromatosis. So we've talked about neurofibromas before. Again, you can see the classic findings, the little stellate elongated nerve cells here, the Schwann cells with mast cells and this fibromucinous stroma that you see. And then if you see multiple of these little aggregations together, clustered together, that's pretty much pathognomonic of a plexiform neurofibroma. Now, this is in contrast to just a garden variety papillated, pedunculated neurofibroma. Now, if you biopsy a patient with neurofibromatosis, all of their lesions don't have to be plexiform, okay? If you biopsy the individual papules on those patients, they look more like this, more like a classic neurofibroma. You know, some patients just come in with one of these. It doesn't mean that they have neurofibromatosis. It's just basically they have just a garden variety neurofibroma. So if you see a plexiform, think of NF1, but if you biopsy a neurofibroma from somebody with NF1, it can look just like this. So they don't have to have any plexiform morphology if the patient has NF1, but if they have a plexiform lesion, you should be thinking of the possibility of NF1 in that situation. Okay, here we've got another syndrome. So if I were to ask you what the diagnosis is of this specific lesion, hopefully all of you would say pretty quickly, oh, that looks like an angiofibroma. It looks like maybe a fibrous papule from somebody's nose or something. Well, when you have lots of these lesions, especially on the face, in the malar area, around the nasolabial fold, actually often not on the nose itself, interestingly enough, like a fibrous papule, commonly can be on the nose. If you see it on the malar areas and you see a lot of angiofibromas, you should obviously be thinking of a tuberous sclerosis. So angiofibroma is probably the most common cutaneous manifestation that we see of tuberous sclerosis. And these can occur not only on the face. If you biopsy the sort of clove of garlic lesions that you see around the finger area, the fingernails, those also look like angiofibromas. And they look more like this, where you get the dilated blood vessels, as opposed to like an acquired digital fibrokeratoma, which can occur in a similar location. That's usually solid collagen with relatively few blood vessels. This thing obviously has a lot of blood vessels associated with it. Now, I'm not sure there's any way to tell the angiofibroma of tuberous sclerosis from the angiofibroma just of a fibrous papule. My experience is these tend to be a little bit more vascular. They may tend to have a little bit of a looser stroma, but as far as I am aware, no one has really taken it upon themselves to look at 1,000 fibrous papules and 1,000 biopsies of angiofibromas from tuberous sclerosis to see if there's a lot of difference between the two. The main thing is just realize that the so-called adenoma sebaceum lesions in patients with TS look like angiofibromas. Okay, and make sure you know tuberin, the genetic mutation. Make sure you know the autosomal dominant inheritance of this. I would recommend knowing the so-called phacomatoses that all sort of cluster together with tuberous sclerosis. Some people call neurofibromatosis one of the phacomatoses, von Hippel-Lindau, TS. So there's about 4 or 5 different conditions that all kind of fall into that phacomatoses category. Now, the next thing, this is one of the angiofibromas from the digit. Okay, so notice it's got blood vessels, it's got stellate fibroblasts. It kind of looks like a clove of garlic at low magnification, looks kind of warty. But as opposed to an acquired digital fibrokeratoma, this has got a lot more vascularity to it. And it's got the more fibroblasts than you see in a classic ADF. So there can be some overlap, but these really generally tend to give you more vessels than you see in that condition. Okay, so that's basically the angiofibroma. A shagreen patch, it basically looks just like a collagenoma, so that's not anything special. If you biopsy the ash leaf macule, there actually are melanocytes in the epidermis in an ash leaf macule, so if you were to do a SOX10 stain, they would be present. They just don't make a proper melanin appropriately. So it's not like they're depigmented like vitiligo. There actually are melanocytes in there. They just aren't making the melanin appropriately because they've got this abnormality genetically. Okay, now we have a lesion that looks like kind of a wart. It's got higher magnification. It's got the clear staining cells at the periphery, some basaloid cells at the very outer rim of these clear staining areas here. And then you've got this sort of thick desmoplastic stromal collagen. This is a tricholimoma, or some people call it tricholimoma verruca, because it looks kind of warty. And if you see these lesions present in multiplicity, especially if they're associated with possibly keratoacanthomas and other things of that nature, you should be thinking in terms of Cowden syndrome. Okay, and I, again, strongly recommend learning all of the various tumors that can be associated with Cowden syndrome. So tricholomomas, especially multiple tricholomomas, think Cowden's syndrome. And the other situation where you can see with Cowden's is a sclerotic fibroma, and that's coming up in a minute, which is associated with Cowden's as well. Dr. Ron Rapini was one of the first guys that made that association. But if you notice here, clear staining cells, relatively homogeneous, no atypicality. This looks just like the outer root sheath of a hair follicle. And over here you can see kind of the more primitive stem cell component. So these are the basaloid cells of a follicle. They look just like the basal cells of the epidermis. And then here you see the outer root sheath type cells. And then you get the desmoplastic stroma, which you see in a desmoplastic tricholimoma, desmoplastic tricholimoma verruca. I'm not sure that they've really looked at this in detail, but the desmoplastic type are not as commonly seen in Cowden's as they are just kind of sporadically. Usually they're not desmoplastic in Cowden's. I wouldn't say that they couldn't be, but this just happens to be a desmoplastic tricholimoma in this situation. So the other entity is so-called sclerotic fibroma. And here you see this. I think I might have even shown one of these as one of our unknowns a few weeks ago. And it looks like this kind of grains of wood morphology, if you will. You get these clefts between these very thick sclerotic bundles of collagen with a decrease in the number of fibroblasts. The lesions are usually relatively small. They're symmetrical. And so if you see one of these, you should be thinking about the possibility of Cowden syndrome. So again, any of these can be seen coincidentally. Sometimes we just see sclerotic fibromas solitary that are not associated with the Cowden syndrome. So I can see tricholimoma verrucas, obviously, that are not associated with the Cowden syndrome, but know that these are two of the lesions that can be seen in Cowden syndrome, and know what cancers are associated with these. Okay, here we've got a basal cell carcinoma that's got some follicular kind of differentiation. It almost looks like a little benign follicular hamartoma. But this developed in I think this was a young person, maybe 15 years old, and she had multiple of these lesions, had palmar pits, had frontal bossing and a wide saddle nose. And basically the situation here is Gorelin syndrome or nevoid basal cell carcinoma syndrome. Now there are about 4 or 5 different nevoid basal cell carcinoma syndromes. There's a Bézek syndrome that's not the perineoplastic type that could be multiple basal cells. There's also Rombo syndrome that's multiple basal carcinomas. And then there's Gorlin's. So make sure you know all of the different ones. So it's not just a single one. But the interesting thing about Gorlin's is if you biopsy the little small papular lesions, especially when they develop in young people, they look like this. They don't really look like typical nodular basal cells. They kind of look like keratotic basal cells, or what's so-called infundibulocystic basal cell carcinomas, or basal cell carcinoma with follicular differentiation. So they can get nodular basal cells, they can get superficial basal cells, they can get erosive deep basal cell carcinomas that get into bone and nerves, and they can be aggressive basal cell carcinomas also, but they get a lot of these lesions too, interestingly enough. And if you take a patient that's got a basal cell and treat them with vismodegib or some of the other inhibitor drugs now for the patched gene mutation, they kind of mature from more typical nodular basal cells. They develop these little follicular-like bud-like structures in them in some cases. So this is probably an early stage of basal cell that eventually could maybe become more nodular or even sclerosing basal cell if this were left alone for many years. But anyway, just remember this: if you biopsy those little small bumps that look like skin tags in patients that have Gorlin's, they look like this. They look like little small infundibulocystic follicular type basal cells. They don't look like the classic nodular or sclerosing basal cell carcinomas. Okay, another genodermatosis. So here we've got what looks like a little plate, if you will, of this kind of thickened sclerotic collagen, okay? And what we really have here, we see it over here, so this is not an angiofibroma. This collagen is thicker. It's actually recapitulating the outer collagen of what's present around a hair follicle. So if you look at these normal hair follicles over here, this is the type of collagen that we're getting in this structure over here. And when you see this without any follicle within it, this is a so-called trichodiscoma. And trichodiscoma is associated with Birt-Hogg-Dubé syndrome. And so this is a trichodiscoma, and this is all related to the touch receptor, analogous to the whisker receptor. It's a nerve type structure that's associated with Merkel cells. It's also associated with like hair follicles, like in a whisker in a cat or a dog. And the process just develops into this hamartoma that's related to the perifollicular stroma. And in the next case, we'll see is this one's an example of a fibrofolliculoma. So it's got kind of features of trichodiscoma off over here, but here we've still got some of the follicle that's associated with it. And so notice we've got the little hair germ that's got this fibrous stroma surrounding it. And so this is more of a fibrofolliculoma. And this is a patient that's got the Birt-Hogg-Dubé syndrome. So you get this, basically think of it as in terms of the perifollicular fibrous tissue that becomes hamartomatous. And sometimes it leaves a little bit of the residual epithelium in the space. Sometimes it doesn't. And it just forms the sort of what basically looks like this sort of thick fibrotic structure here that would be called a trichodiscoma. And this is related to the ability of animals that have their whiskers, and they use that to sort of detect things when they're sniffing around. You know, it's actually a way to, they interact with their environment by using their whiskers. So it's not just there for ornamentation, it's actually the animals use it. In humans, we don't really have as many whiskers left anymore on us. And so basically this just is a hamartoma that's a vestigium of what is present in animals. The thing about this is these patients can get these lesions that look like skin tags or fibrous papules or little skin-colored bumps on their head and neck area most commonly, and they're associated with renal cell carcinoma. They're also associated with pneumothorax. So it's important to make the diagnosis because you don't want to let the patient go with an undetected cancer or get a spontaneous pneumothorax with this pulmonary blebs that rupture that can be life-threatening in some cases. So you want to make sure if you see this, that you make the diagnosis and the patients get treated appropriately. It's also autosomal dominant. The carcinomas that they develop in their renal system tend to be less aggressive than spontaneously developing renal cell carcinomas that develop in patients that don't have Birt-Hogg-Day. So that tends to be a theme, that if you develop a germline cancer, tends to be less aggressive than the same kind of cancer that occurs spontaneously, interestingly enough. Okay, now we've got a sebaceous lesion, and notice that it's got this cup-shaped exoendophytic architecture. And you've got some, this is well-differentiated sebaceous cells. These cells, they're the primitive stem cells at the periphery, but you've got very well-differentiated sebaceous cells forming a cup-shaped lesion. And this is classic for a sebaceous adenoma. And we see sebaceous adenomas, obviously, when they're present in multiplicity. If we just saw one of these, we'd probably be less concerned about it. If we had a number of these, then we start thinking of the Muratori syndrome. And this is a situation where there's microsatellite instability, where you lose expression of certain genes, and the genes that we look for are MSH2, 6, MLH1, and PMS2. And many individuals will do some stains on this looking for loss of staining. And if you see loss of staining in the skin lesion, it is associated with a higher incidence of developing the patient having the Muratori syndrome. Now, it's not 100%. We see a lot of patients that have loss of that expression, but they don't have classic Muratori. And we see some patients that don't have loss of expression and actually do have Muratori. So it's not 100%. A lot of people don't test for it. We do in some cases in our laboratory. And it's a fairly common entity. I think of the various syndromes that we see, this is one of the more common ones. We see a lot of these patients that have microsatellite instability. A lot of patients have colon cancer and have microsatellite instability there. So microsatellite instability is relatively common in the general population as opposed to a lot of other various syndromes and whatnot. And this is another sebaceous lesion. And notice in this case, it's associated with more of the primitive germ-like cells. So we still have some sebaceous, mature sebaceous cells within the lesion, but the bulk of the cells here are comprised of the germinative cells that reside on the outer part of the sebaceous gland. And so there, these things have proliferated massively, if you will, and formed this lesion that basically, in this case, we termed a sebaceous epithelioma. Now, if you have a relatively small lesion that's kind of cup-shaped, and I don't know whether we have an example of one of those, but it looks kind of like the sebaceous adenoma, but it's comprised of greater than 50% of the germinative cells, we call that a sebaceoma by convention. If it's got more than 50% of the well-differentiated cells, it's called a sebaceous adenoma. If it's got more of the primitive cells, more than 50%, then we call it a sebaceoma, kind of like a trichoepithelioma, but with sebaceous differentiation. If it sort of doesn't really, read the textbook, if you will, and looks a bit funny like this, we end up sometimes calling it a sebaceous epithelioma. And that doesn't necessarily mean that it's cancer, like it's sebaceous carcinoma. Generally in sebaceous carcinoma, we see a lot of asymmetry. We see a lot of mitotic figures, we see a lot of necrosis on moss, and none of that's present here. So we thought this was a benign lesion, but this also can be associated with Muratori syndrome when they look like this. So if you see a funny sebaceous lesion, especially off the head and neck area or whatever, you should think about the possibility of Muratori, even if they just have one or two of them in that situation. And a lot of times it can be kind of a precursor to the fact that it's got it. Here's another example. Again, this one more well-differentiated areas, but notice that this one's got a lot more atypicality. It's got a lot of mitotic figures in here. It's got necrosis en masse. So we don't know how big this lesion is. It's just a shaved biopsy. But this is an example of a sebaceous carcinoma. And sebaceous carcinoma can be associated with Muratori as well. So if you see that, you should at least think about it. Patient may just have the isolated sebaceous carcinoma that occurs in the eyelid in an older individual, but you should always be thinking about Muratori when you get sebaceous carcinoma, or you get kind of a funny sebaceous lesion that looks like maybe a sebaceous epithelioma or sebaceoma that's in a funny location that doesn't look like a sebaceous hyperplasia, for example. So you want to always be thinking in terms of the potential of Muratori syndrome there. Okay, the last one we're going to talk about today, and hopefully you'll be able to recognize this, is an angiocarotomy. I'm going to turn it over. As you can see, it kind of looks a little bit like a wart. It's got these dilated blood vessels in there and these almost always have lots of red blood cells in the lumen of these vessels. And sometimes they'll get this kind of pinkish fibrin-like material in there as well. I'm not sure it's really fibrin, but it may be lymph or whatever. But it's very common to get this pattern. You get this verrucous epithelial hyperplasia. The lesions tend to be relatively small. They often have a collaretive epithelium at the periphery, and then they almost always are just chock full of red cells in these. And when you see them clinically, they look black. They almost look like caviar. And there's several different forms of these. There's the Mabelli type. There's the solitary type. There'd be the type that's kind of circumscriptum, if you will. And then when you get the widespread type, that's where you start thinking about the possibility of the syndromes. And there's several of these. There's the number one is the Fabry disease that you should know about, obviously. Again, I believe that may be X-linked, as I recall. I haven't looked at the genotype of this in a while, but you need to know that, and you need to know the genetic abnormality. You need to know the symptoms that these patients have. They'll often get GI problems with these when they have this condition. There's also some other genetic syndromes that are associated with this, like fumarate hydratase deficiency may be associated with angiocaratomas, and that's also recently been looked at as being associated with porokeratosis, interestingly enough. So I would recommend learning all of the various biochemical genetic abnormalities that can be associated with Fabry's disease. Not Fabry, but with angiocaratomas, there's about 3 or 4 of them. So make sure you bone up on those and learn those. But these are the kind of questions where the board's going to show you a relatively straightforward entity that you should be able to diagnose. They might show you a clinical picture of a patient with multiple angiocaratomas, might show you like one histologic image like this. It's maybe on a digital image. We used to call them Kodachromes, but no more Kodachrome today. And then they might say the most common, or they say, which of the following genetic abnormalities can be associated with this entity? And they might ask you Fabry's, but they might throw some other things in there like blue rubber glove nevus syndrome. Well, that wouldn't be, angiokeratoma. Those don't show angiokeratomas. They look like more kind of cavernous or capillary angiomas. They don't really look like angiokeratomas. They might show you some other vascular things, and you should realize that no, those aren't associated with angiokeratomas. Fabry's is, and some of these other syndromes that I mentioned before are, and just make sure that you know what those are, and you'll be able to get the diagnosis. And I would expect you'll probably get a question on Fabry's. I would expect that. So you may as well go ahead and learn it now and be prepared for it. And then you've already gotten one question right, and you can move on to memorizing biochemical pathways and the porphyrin pathway. So hopefully you won't have to do that. And you can also focus on learning other more classic dermatopathology kind of questions that they're going to ask you. So that's a summary and an overview of some of the genodermatoses. It's not all of them, but it's a nice example of some of the types of things that you're almost certainly going to face on the exam. And hopefully it's been helpful to you. And we will reconvene next Wednesday. I'm not sure what the topic is, but we'll go through some other interesting things for you that'll hopefully help you as you begin to prepare for your board examinations. Thanks again, and we will see you next week.